I'd like first to thank the organizing committee for inviting me to be a speaker in this conference. And basically, as they mentioned, it was supposed to be a debate with Dr. Fatma Al-Hamadi. Unfortunately, she's not feeling well and she couldn't attend. So what I'm going to do is I'm going to try to balance my presentation. It was pro medications. Now I'm going to try to balance the talk. And before I start, I'd like, again, a raise of hands. They already started that, but I'd like to ask the audience, who is doing regular exercise and who is continuing with lifestyle adjustment? Just show of hands. Who's doing it? So probably a third. Then this third, how many of you continue doing lifestyle for more than 1 year? 2. Who continued doing lifestyle adjustment for more than 5 years? 3, 4. So I think with this I made my point regarding lifestyle adjustment. And for this talk, I have no conflicts of interest. So Dr. Fatma Al-Hamadi was supposed to talk about studies that says lifestyle adjustment is much better than medications. And I was 100% sure she's going to quote the DPP program, which is Diabetes Prevention Program, which says that lifestyle adjustment is associated with around 58% reduction in the risk of developing diabetes. But probably shouldn't mention that within the same study, people who were using metformin, especially young people, and those with BMI more than 35 has benefited much more than lifestyle adjustment alone. People with gestational diabetes have also benefited, and there was more than 50% reduction in the risk of developing diabetes compared to lifestyle adjustment. And I'm sure should also mention that in the US Diabetes Prevention Program outcome study, which was continued for more than 15 years, there was 34% reduction in the risk of diabetes at 10 years, and there was around 27% reduction at 15 years. And she is looking in that way at the full half of the cup. If you look at the other side, it's around 66% of patients did not revert to normoglycemia. And 73% did not revert to normoglycemia at 15 years. And in the same study, they found that using medications, especially in those with higher A1C, more than 6, and higher baseline fasting glucose, more than 110, they benefited much more with medications. Now, that was plainly the message she's going to deliver. And what I wanted to say is, yes, in the DPP program, lifestyle has reduced the risk of diabetes by 58%. But look at this study. It's called ACT NOW. And this is about pioglitazone. The use of pioglitazone in this study compared to a placebo has reduced the risk of developing diabetes by, what happened? Okay, it reduced the risk of developing diabetes. If you look at the hazard ratio is 28 by 73%. And this is not the only study. All the studies on TZDs have shown a reduction of 52%, 62%, 62%, and 70%. That is more than what lifestyle alone would do. Now, I'll take you to other medications, and I will choose select trial. This is a new molecule, and we're talking about pioglitazone. Sorry, we're talking about semaglutide, a once-weekly GLP-1 that is associated with significant weight reduction and reduction in A1C, and in diabetic patients, a reduction in cardiovascular outcomes. And you can see the rate of reduction or in diabetes, the rate of remission of diabetes is quite significant. And if you compare, if you look at all population, just look at the first graph on your left hand. All patients before at baseline, which is the dark blue, there was 80% of patients had a higher risk of progression. That has dropped to around 30-something. That's more than 60% reduction in progression to diabetes, rate of progression to diabetes. And if you look at people who lost significant weight, more than 15% of their weight, see the rate of progression has significantly rate of reduction or regression to normal glycemia significantly reduced with semaglutide. And now the other molecule, which is tirzepatide, Mounjaro, if you look at the reduction based on the weight at 72 weeks, the gray is the placebo, and you can see the reduction at 72 weeks at different doses of tirzepatide. So the first point I wanted to make is using medications is as efficacious as lifestyle in reducing the risk of developing diabetes. Not only that, I'm going to show you this. This is a SURMOUNT trial. And look at the number, 94% reduction in the risk of developing diabetes. That you will not get, 100% you're not going to get with lifestyle adjustment alone. Now, the question is it just about remission of diabetes? Whenever we treat a patient with diabetes or pre-diabetes or even a just obese patient who doesn't have dysglycemia, we always focus in reducing cardiovascular risk. We want to reduce the risk of developing microalbuminuria and renal disease. We want to reduce the risk of developing heart failure. We want to reduce the risk of developing myocardial infarction. So this is the IRIS trial. IRIS trial basically is a study where they recruited patients who developed stroke, who are not diabetic. They don't have diabetes. They just had a stroke, and then they started them, randomized them into either pioglitazone or a placebo. And what they found, that the group who used pioglitazone had less risk of developing a second stroke. So we have patients with pre-diabetes with just a stroke, and then use pioglitazone has reduced the risk of developing another stroke. So it is beneficial. And you can see the amount of reduction in the risk, 24% reduction in the risk of developing a second stroke. And when they analyzed the IRIS trial, if you can see at the stroke or myocardial infarction has been significantly reduced by 24%. If you look at the risk of progression to develop diabetes, it has been reduced as well significantly by 52%. And this is a sub-analysis of the same study where they looked only at patients with pre-diabetes. And you can see, just look at the numbers and I think you'll be convinced. 40% reduction in stroke and myocardial infarction, 33% reduction in stroke alone, 52% reduction in acute coronary disease, and heart failure and stroke reduced by 38%. And as I mentioned, you can get up to 80% reduction and regression of glycemia. And this is now the SELECT trial, where we used semaglutide in patients who are not diabetic. non-diabetic, we use semaglutide 2.4 milligram. And what we could see, just look at patients who at baseline had an A1C between 5.7 to 6, significant reduction in MACE, which is non-fatal stroke, non-fatal MI, and cardiovascular death. 3 of them significantly reduced in non-diabetic patients. Look at the expanded MACE. Look at MACE with all-cause mortality, significantly reduced with semaglutide. Now, if you look at coronary revascularization, significantly reduced. Cardiovascular death has been reduced only in patients with an A1C between 6 and 6.5 at baseline. So what I wanted to deliver here is that managing prediabetes is not just about numbers and reducing the A1C or a fasting blood glucose. It is about reducing the overall risk of patients with prediabetes. And this is just a proof of what I just mentioned. If you look at the ADA guidelines in 2024, it says metformin for prevention of type 2 diabetes should be considered in adults with high risk of type 2 diabetes if their age, if they're young. And that's what I mentioned in the DPP program, that younger people did benefit from metformin. So if they're young and has a BMI more than 35, if they had a higher fasting blood glucose, if their A1C is between 6 and 6.4, and if they have gestational diabetes, and they gave evidence level A. And if you look, and this is new, it wasn't in the previous guideline. They said, look at your patient risk. We need to reduce cardiovascular risk, and to reduce it in people with a history of stroke and evidence of insulin resistance and prediabetes, pioglitazone, maybe, and I don't like maybe, because things are going to change, may be considered to lower the risk of another stroke and myocardial infarction. So, what are the future directions? This is the current guideline. Maybe things will not change in the guidelines in 2025, but look and observe for the guidelines in 2026. Likely, it will be pioglitazone should be considered in patients with a stroke and prediabetes and insulin resistance. And probably GLP-1 and GLP-GIP are going to be introduced early with lifestyle. This is exactly what happened with management of diabetes. We used to say lifestyle and then consider medications. And I think the next guideline is going to say prediabetes, start lifestyle with medical therapy. So, in conclusion, we still have time. It's okay. In conclusion, lifestyle intervention is an essential component in this glycemia management, but alone is not enough. Lifestyle intervention usually fails, and I think the poll was a proof of that. Medical treatment can be as effective as lifestyle in diabetes regression. And medical therapy has the edge on top of lifestyle adjustment in reducing cardiovascular risk. So new molecules, whether GLP-1 or GLP-GIP, are probably going to be considered in the new guidelines because they are associated with significant weight loss. And thank you very much.